Thank you very much for giving me the opportunity to share my experience in the UBE clinic applications in cervical cases. I'm Dr. Zhang Wei from China. Today's content include indication, basic anatomy, tools, anesthesia, position, locations of portals, and surgical steps. Indication include the keyhole for the discectomy and decompression of the cervical nerve canal, and the cervical ULBD for the cervical spondylotic myelopathy. The basic anatomy is similar to the UBE lumbar procedure. We often doctor in the midline and there is nearly no muscle, and then we move to the lateral side. We will see the laminar in the first scene. We can see the lateral muscle, and we work in the midline and then move to the lateral mass. UBE cervical case equipments is a simple and a relatively small number of devices required compared with the lumbar procedure. Include endoscopy, IF, plasma, special tools, small size kerrison punch, and high-speed drill. Endoscopy includes 0 degree and 30 degree. 0 degree is similar to the open procedure, so is the first choice. How about 30 degree? We should rotate the endoscopy to see interesting area, and the distance between view portal and work portal is 2 centimeters. So at such short distance, the 30 degree endoscopy and the instruments are prone to conflict. But maybe the ventral structure of the spinal cord is easy to see. I often use the two types of the IF produced from the Bounce company. The big one is used to expose. A small one, our name is Neurosurgery, and to do the bleeding control around the nerve root. Special tools include the small size dissector, and there's a half tuber, and the small size UBE retractor for the autoflow fluently. And this protector sheath is used to remove the osteophyte near the nerve root. You can see we insert the protective sheath, and we protect the nerve root. Then we insert the drill bore through the protective sheath to remove the osteophyte. Kerrison punch includes 1 millimeter, 2 millimeter thin blade, 110 degree and 130. And 2 millimeter thin blade curved punch is used to the cervical ULBD. We master the dural no touch technique. This is the angle kerrison punch. High speed burr, I often use the short handle because short handle is stable, I think, and nearly no exposed drill root. There is no exposed drill root because it often can damage the endoscopy and the muscle. 2 millimeter and 3 millimeter diamond bore is often used. Anesthesia, we need to control the low blood pressure and deep anesthesia and this jet plane position, and to keep the curve of the cervical spine in the level. Location of the two portals. I prefer to the midline of the lateral mass, and I draw a line between the two pedicle, and the midline, the blue line, the cross point above this point, about 1 centimeter is the view portal, and below 1 centimeter is the work portal. The lateral X-ray show the endoscopy and the instrument meet together in the facet joint. This is the picture during the operation. The laminar and the base of the spinal process is a safe dock area, I think. The endoscopy and the instrument meet together the surface of the laminar. A surgical step, V-point is very important anatomy landmark. You can see the V-point is the inferior margin and the upper margin and the medial margin of the facet joint. This is the bone work start point. I often use the size of the drill bore to measure the decompression area. We cannot go beyond the 50% of the lateral mass. You can this video shows the lateral mass joint, facet joint. You can see the joint. Start point is the V point. We start from here, the V point. We use the 3 millimeter diamond bone. The dividing line of the flavor ligament, the lateral margin of the flavor ligament, you can see here. I use dissector to separate the lateral margin of the flavor ligament and the membrane. We often find this membrane on the surface of the nerve root. This is not the dural membrane, so it's safe. This is the decompression area. I draw the picture. You can see the medial wall of pedicle, the two pedicle. And this is the nerve root, this is spinal cord. How to make sure the decompression area? You can see the lateral wall of the pedicle and the medial wall of the pedicle. Yeah, you can make sure the decompression area. Because the lateral wall of pedicle is located in the 50% of the lateral mass. So we decompression here. Another method, I use the size of the drill bore to measure the decompression area. After discectomy, and we can do the further decompression of the spinal canal. The disc herniation is often located in the axillary area. At last, we see the medial wall of the two pedicles. We finish the keyhole decompression. This is a keyhole procedure. The case one is a giant osteophyte. You can see the huge osteophyte. I will do the contralateral approach to remove this osteophyte. The above is midline, the below is the right side. I expose the laminar. You can see the upper margin of cervical fold. Cervical 5, this is the V point. You can see the inferior margin of osteophyte. I use a small IF. This is the upper margin of osteophyte. You can see the free bone fragment. I remove the free bone fragment. Separate the free bone from the spinal cord. So I think the small size plasma is very safe, especially for the cervical case. We can see the contralateral root and the contralateral facet joint. After further removing bone, the decompression finished. Yeah, this is a post-operation, the CT. The case 2 is cervical ULBD, the classic procedure. We start point is from the V point. Make thin the laminar. You can see the inner plate of the laminar. This is a flavor ligament, and this is a up margin of the flavor ligament. Then I make sure the start point of cervical 5. After removing the laminar, the decompression finished. Anatomy is very important, especially V point. And we must make the docking point in the midline. And we choose the right tools and right operation indication. The anesthesia position is also very important. Precise location, especially work portal, is very important. How to make sure the decompression is also important. We have 2 methods. Thank you very much.
Thank you so much, Dr. Wizang. This was a wonderful and a very, very informative talk by you. Amazing, amazing work, especially with the osteophyte removal. Really impressed with your work, sir. I am a fan of yours. I can declare that publicly today. And I think we will now start with our panel discussion. Dr. Bennett, can I please request you to get all the speakers? And if the public have any question, I'd also like Dr. Anand Kavi to join us in this panel discussion. So,
yes, Malcolm, I'm here.
We have 10 minutes on with us. If anybody has any questions, please regarding. So I hope Dr. Mohammed Assaus is also there with us right now. I personally have one question for Dr. Mohammed Assaus. Dr. Assaus, are you there with us?
I hear you.
Yeah. Dr. Mohammed, one personal question that I have for you is, what has been your personal incidence of transient root paralysis and root dysesthesia following transforaminal endoscopic discectomy?
I probably, in 500 cases, I remember 1 or 2, and it was in my initial cases, basically, when I went too steep or too straight on the disc. So after that, I immediately adopted the cranial-caudal approach. I think this is an access issue usually where the cannula sits on the exiting route during the access. And this is why I think you are much more safer and less likely to get this complication by going just that 10-15 degrees caudal and avoid the exiting route altogether.
Thank you so much. Thank you so much. Anybody else with any other questions, please, from the public also? Do we have any questions for our panelists? Dr. Wizang, one question directed to you. Personally, whenever I do cervical endoscopy, I definitely follow what you have been speaking about. I identify the V. And I did appreciate your suggestion that we should not remove more than 50% of the lateral mass. So that is 2 things that I desperately follow. I believe in dividing my cervical work into 2 parts. One is when I wish to just trace a root or to decompress a root, then I prefer to go more laterally. Or if I prefer to go centrally, then I prefer to do more central decompression. I try not to mix both together. I try to be more specific in my approach. Regarding your case of tackling the cervical osteophyte, I found it very, very intriguing, very beautiful. We don't get to see such cases in our Indian subcontinent, unfortunately. So it was interesting to watch your work over there. Dr. Baban, it was wonderful to hear your concise talk and your experience about 500 cases of PSLD, which you have very beautifully divided. into cases that required only discal work and cases that required stenotic work. I appreciate your approach and your ability to deal with posterior osteophytes that specially compress and elevate the root in its exiting part of the foramen. And the ability to do that in a uniportal approach is fantastic. It's really fantastic. So hats off to you there. And Dr. Podal, you are one of our beautiful panelists who spoke upon pain generator. This is a concept which has been really highlighted by one of my great mentors, Dr. Satish Chandra Gore also, who has been speaking about pain generators in the spine. So definitely the end goal of all surgical work in the spine is relief of pain. And that's what we all basically aim to achieve. So that's a very wonderful talk that you have delivered. Dr. Pang, Dr. Wu Pang, yours was a wonderful talk. You mixed all branches of endoscopy right in the initial program itself. It was like delivering a nuclear bomb in spine endoscopy, and I really, really appreciate what you spoke upon. The future of spine endoscopy is going to be a 360-degree approach. It's going to be a merging of all branches of endoscopy. There is going to be nothing like specialization in endoscopy, PLD, UBE, uniportal. It is basically just going to be achieving proper decompression, achieving pain relief, and setting out the gold standards that we actually are today. I don't think that microscopic endoscopic discectomy with a microscope is any more the gold standard. I feel that with the fluid medium that we are using, better visualization, camera actually at the chip or the end of the scope is the future, and the world is well on its over there. So I would like to conclude this first session. If any of you as speakers would like to raise a question, please do it now.
Yes, Malcolm, there is a question from the audience.
Yes, please.
There is a question that kindly describe the anatomy of V point. What do we mean by V point in case of posterior cervical endoscopy? So
I think I will ask Dr. V, our panelist himself to speak on it. Dr. G, if you can speak on that, please. Hello. Our panelist is gone. Hello, Dr.
Yeah,
Hello,
Dr. V. Zhang.
Yeah. I see the question. Javier explained the viewpoint. The viewpoint is a very important anatomy landmark in the cervical endoscopy procedure. Is formed the inferior margin of the laminar and the upper margin of the laminar to form a word V. And the V point is located in the medial margin of the lateral mass. We do the bone work from the V point and to the lateral side to expose the nerve root. And after remove the bone of the V point, we can see the lateral margin of the flav ligament and the membrane on the surface of the nerve root. We separated the flav ligament and the membrane, and we can see the nerve root. And we go to the below pedicle, mid wall, and above the mid wall of the pedicle to do the decompression of the nerve root and remove the disc coordination. So V point is a very important start point for the bone work. Thank you.
I think I have with me a sample, a specimen over here. And I would like to point out that the V point is where these two points meet, where the upper and the lower lamina meet to form the lateral mass. That is the V point. Now the V point, when you decompress about 30% or 50% of it, Anteriorly, you have decompressed and exposed the entire discal surface. You don't need to go more laterally. So that is exactly what Dr. Jai has been trying to explain to all of us. And I hope that this satisfies you. Thank you so much.